Yeah, give me the power. Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen, and today I'm joined by my co-host and my good buddies, Dr. Susan Hudson from Texas Fertility Center
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hi guys, what's new?
Well, um, we're in the midst of summer right now, and this episode's going to air maybe a little bit later, but I'm getting ready to have some people over at my house, and I've never seen so many cicadas in all my life. And I've lived through the 10-year one and the 3-year one and the 5-year one. This one's pretty big, though. We have lots of cicadas everywhere. But the good news is they don't bite, and
New. Oh my
but they're really
goodness.
annoying. They're annoying.
The other night we were driving home from a graduation party at one of our friends' houses, and we drove out of the neighborhood, and the neighborhood's kind of dark because it's out in the country, and we pulled up to the stoplight, and my husband's driving, and I look over, and at 12 o'clock on the steering wheel is this like 4-inch long cicada standing on the top of the steering wheel. And I'm
Driving, was he driving the car?
Well, we were forced to like stop at the light, and so like I was trying not to like freak my husband out because he like I didn't want him to think like an oncoming car, but I was like, okay, so stay still, and I'm like cicada on the steering wheel, and he rolled it,
Cicada at 2
you know,
o'clock.
and popped it out, and then we get home, and as we like are getting out of our garage, there's a cicada on our car, which we just left alone. But the funny thing is, it was there until the next day when we left and literally stayed on our car, and we watched it, and it was probably a good like 7 minutes of driving that this little cicada like held on, and you could see him like all moving around and trying to get different aerodynamics and stuff. It's not little, they're gigantic. I'm like,
My corollary to that is I learned as I was using the leaf blower to blow all the leaves and junk off our patio, those little things are aerodynamic. I think Elon Musk needs to like study cicadas because I mean, I could put the leaf blower on the big turbo power, and I swear, as hard as I tried, some of those cicadas couldn't blow away.
they must have like super sticky feet, whatever they're called
Yeah.
on insects.
So, Carrie, out in Las Vegas, have you been blessed with the cicadas, the 13-year cicadas?
Yeah, a couple years ago, and this was in the middle of the pandemic. And so it was like plagues and infestation, all of it happening at the same time. But there were so many cicadas. I mean, think about the Vegas Strip. It is all lights. Like the entirety is lights. And so there were videos going around at the time where people were walking down the strip and you could hear crunch, crunch, crunch
Oh,
because it was just everything was completely covered, even the floor, even the sidewalks. And so yeah, we get them periodically. We get grasshoppers periodically, and I'm just not like, I don't know why, because scorpions are so much
more
more
dangerous.
painful and
Yeah.
deadly and dangerous. But like
You'd
scorpions,
rather have a scorpion than a cicada?
scorpions I'm just used to. I don't like them, but I know how to kill them.
So,
And
is there anything? I'm guessing cicadas eat like greenery. I don't
Yeah,
know.
yeah, I think they do actually. I think I could be wrong about that. But what eats cicadas are snakes. So people have said to watch out for snakes because there's a lot of
Um,
snakes around. And I've
mm,
also heard from a friend of a friend of a friend, and I didn't do this. Let me just say this. I'm from the South, but I don't eat cicadas. But people have been known to make cicada stuff like pies and stuff, and they taste
ew.
like peanut butter, supposedly. But I'm not going to try
So are they
it.
ground up or dipped in
I,
chocolate, or what do they do?
I have no idea. And I have no idea why you would want to do that. But hey, I guess there's people out there that like to try crazy
I
things.
think I
What
would
was
more likely eat a grasshopper than a cicada.
because
termites
why?
taste minty.
What
Termites
now?
taste minty.
Termites taste minty.
This
Have
If
is
you
you're ever
eaten
out
term?
hiking and you spot termites, they're a good breath freshener.
Get out.
Yeah, yeah.
Oh,
And they're so tiny that they're not super objectionable to eat. Although one
have
of my
you eaten
partners,
one? Have you eaten one?
uh-huh, that's how I
You've
know
eaten
that
a
it's,
termite before with it
uh-huh.
alive?
Well, until I ate it.
You
And
like you
a
ate it
lot.
where when it was wiggling like around, like in your
Termites are
mouth?
tiny, 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 tiny. The cicadas you're describing are like,
I
Big
mean,
and crunchy.
potatoes being like juicy, icky.
yeah,
Oh.
cicadas you would get a legit crunch from. Termites are so tiny.
And my cicadas have those ugly red eyes too. You'd be staring at those ugly red eyes.
Yeah, not
Mm.
not in for that. One of my
Uh-uh.
partners went to Africa and brought back chocolate covered larva, which actually tasted fine, but it was the mental that I couldn't get over of I just can't make the jump of being okay with it. But if I hadn't known what I was eating and if I hadn't looked at what I was eating, would have been fine.
And in Japan, and I'm certainly no expert, so anybody from Japan, if I'm saying this wrong, I'm sorry, but there's some sort of bug or something that Japanese people have for snacks, right? I have to do research on that. I thought you
Yeah.
guys might know something about that. But yeah, one of my friends who served in the military and was over in Japan, there's something you can buy like in a bag and you like eat it, and it's like an insect of some sort, I think.
Hmm. Okay, let's do a
Hmm.
question.
Now
All
that we have
right, Susan.
destroyed eating for the
On that
rest of
note,
the day.
on to the question, Susan.
On that note, here is our question of the day. Love your podcast. It's been a lifesaver. Um, my question is, do you ever recommend your patients repeat a failed HSG test? My findings of my HSG: right tube not visualized, left tube with fill to mid tube of normal caliber, cannot confirm spill. In an attempt to visualize, 5 French balloon placed with full fill and beginning to fill left tube, catheter self-injected multiple times, uterine filling defects noted, cavity normal size with triangular contour. She's 37, AMH 3.11 PCOS. IUI is covered by insurance, but not IVF. Heard episode on PCOS success with Clomid, so wanted your thoughts. No time is not on my side. Wondering if spasm during procedure could have caused, or would you consider tubes blocked or damaged? Doctor recommended straight to IVF. That's a great question. I love it.
That is a
Yeah.
really good question. So my thoughts on that, she mentioned lots of filling defects.
Mhm.
That's where I would start. And so I would go in with a hysteroscopy. I would figure out, or in cross-check it with ultrasound ahead of time, kind of see what those filling defects are. Sometimes they're fibroids, they're polyps, they're scar tissue, whatever it is, deal with those first. Because sometimes when you go in, you can see that there's a big old polyp that is blocking the, in this case, right tubal ostia, the opening into the right tube. And so maybe that's why it's registering as occluded. And so that's probably the first place I would start. When someone says there is occlusion mid-tube, like she described in her left tube, that's usually legit. It's if you see a tubal spasm, the spasm occurs right at the opening into the uterus. So the tubal spasm does not occur halfway through. So if you get fluid dye halfway through and then it stops, that's a probably legit occlusion. What I'm curious about is the right side. Is that actually blocked from tubal damage? Is that blocked from a polyp getting in the way? Or was that a spasm? Now, when you've got one side that's damaged, there's very little distance between the openings of the two sides. I mean, it's a couple of centimeters. The uterus is not that big when it's not pregnant. And so anything that can go and tick off the one side can tick off the other side. And so I do worry about the impact of damage that if one side is truly blocked, the other one's probably not functioning well.
One
What
thing
do you
that
think, Susan?
One thing that I often do in this situation is, especially if we know we're going to go to hysteroscopy to take care of polyps or fibroids or adhesions that are causing filling defects, I'll repeat the HSG while you're asleep under anesthesia.
Mhm.
And so
Yeah.
what I'll do is I'll start off with the HSG, see if the tubes are open. And I would say 9 out of 10 times they usually are open.
Mhm.
And then do the hysteroscopy. And if the original HSG from the beginning of the surgery did not show me open tubes, I'll repeat the HSG after I've taken care of the hysteroscopy. And that way, you don't have any filling defects that are temporarily blocking. So in that situation, that's what I would do. Sometimes I have people who live a big distance away and that type of thing isn't necessarily available. So I tend not to repeat HSGs at a radiology center. I try to do it while somebody's asleep if there's something going on in the uterus too.
Yeah, I just recently did exactly that, and somebody I repeated that. It's hard to get the equipment in there, and logistically, it's kind of challenging. But I did it, and her tubes were both open, and so I would definitely do that. The other thing that we can do that we'll do a lot of times is do a saline sonogram and repeat it in the office. A lot of times, I'll give patients Valium to kind of help the uterus relax because it can be due to spasm. I have seen a partial tubal fill, particularly if, but and still be open in the future. We demonstrate later if like the uterus is tilted in an unusual way, or sometimes if the balloon is cannot, like if you've had babies before, sometimes it's hard to really get a good occlusion with the HSG balloon. So sometimes if the fluid leaks backwards, positionally, if the right tube is the one that's hanging down, it's more likely to spill. And sometimes the left tube can partially fill, for example, if you can't get a good occlusion. So those are really the kind of the main things that I would think about. So I would either repeat a saline sonogram if I wasn't necessarily going to go to the OR and look. Um, and if I'm going to go to the OR and look, then certainly we could do one in the OR and just check the tubes at that point.
Sometimes a shot of Toradol, like half hour, 45 minutes
Yeah.
before you go in to do the test, that can help too, because it helps with the spasm from a different direction.
Ibuprofen would probably be
Yeah. Yeah.
equivalent to something like that.
Yeah.
Yeah, and I will say too, sometimes you get worse news though. Sometimes if the tube is blocked where it connects with the tube, like if you don't see anything spill there, that a lot of times that can be spasm. If it goes to the far end and there's blockage there, that's probably the real deal. I just had a patient a couple of weeks ago who had had an HSG a while ago and had partial fill of one tube and spill from the other tube. So it'd been like 2 or 3 years. So she wanted to repeat it again, and we did. This time we saw that tube completely filled, but it was a distal hydrosalpinx. It was a blockage at the end of the tube. So
Mhm.
sometimes that can indicate that there is some scarring in the tube, and maybe it couldn't make it through then, but for whatever reason, it did most recently.
Good deal.
All right. So today we are going to talk about a very frustrating diagnosis for some people called unexplained infertility. And so we'll kind of start out and talk a little bit about the definition and talk about kind of how we arrive at the diagnosis of unexplained infertility, which feels like not really a diagnosis. So Susan, start out and tell me kind of what's the definition of unexplained infertility?
So the definition of unexplained infertility means we have done all of the tests that are reasonable at that point in time, and we have not identified a definable, reasonable cause of you not being able to get pregnant. So that's often a hard thing to swallow, but the easiest way that I can explain it is if we wrote a book about everything we know about infertility, and then we wrote a second book about all the testing that we have, that second book is probably less than half the length of the first one. And the easiest way to understand this is that sometimes people will be like, well, how do I know if I've had implantation? Well, unless you've had a positive pregnancy test, me nor anybody else on this planet is going to be able to tell you if you've had implantation. But we know that sometimes implantation happens and it fails. And so that's kind of the idea, is that we know that there is a problem. You have not been able to conceive over a certain period of time. All of our testing that we have done to date, which is appropriate for your path in the fertility evaluation, is normal. And then we have to decide what to do from there.
Mhm.
So, Carrie, what are some reasonable tests that we typically do? There's lots of things you see on the internet, but what are the sort of the reasonable common tests that most reproductive endocrinologists would do?
So when you start looking at testing, the things that we're looking for that you need in order to get pregnant: uterus, tubes, ovaries, sperm, and then general good health. So those are the major categories where testing falls in. So usually the first thing that we're looking at is ovarian reserve testing. And we do that on the third day of your cycle, where we get a vaginal ultrasound that looks at antral follicle count, or AFC. And those are the itty bitty teeny tiny eggs that have the potential to grow that month. This is not your total number of eggs left in your ovaries, period, end of story. This is that month. And so we take a look at that. And at the same time, we get blood work where we look at the FSH and estradiol, along with usually LH and progesterone, and look at the communication between the brain and the ovaries, because at that point, they should be quiet. They should be talking to each other very nicely in an inside voice. There should be no yelling going on. So if those levels are high, that means that somebody has gotten a little out of control and the situation is not super friendly. And so We take a look at those, and then we take a look at the AMH, which is the storage hormone. So this is every single egg that's in deep, deep storage. So not the follicle count, but the deep storage that you can't see. Each one of those itty bitty teeny tiny eggs produces a little bit of AMH, and we look at the total amount of AMH in your blood to get an idea of low, medium, or high egg reserve, with the thought of, if you have low egg reserve, it's kind of like going to the grocery store and being in the produce department on like 10 p.m. on a Sunday night after the weekend hordes have come through. Like, there will be fruit there, but it's not going to be the same fruit that you find at 7 a.m. on Saturday morning right after they've restocked. And so, you can get it. It's just, there's more bruises, there's more gouges, there's more,
See,
not.
I think I've become such a better reproductive endocrinologist by talking to you two, because I have so many better analogies than I ever had before. I've got so now this fruit analogy, I'm going to use this. But sorry, I digress. You were doing a great job, Carrie. Go ahead.
So that's the ovarian reserve testing that we're going to do. We're going to also do tubal testing, where we make sure the tubes are open, either by an HSG, which is using dye and X-rays or fluoroscopy, or we're going to do a hycosi, which is using a fluid solution and ultrasound, and we're going to check to see if the tubes are open on both sides. We're going to do uterine testing, saline ultrasound, where we put a little bit of salt water inside your uterus with a vaginal ultrasound to make sure that when it opens up, there's no scar tissue, polyps, anything obstructing the ability for the egg and the sperm to come together and implant. And then we're going to do sperm testing, where we look at the semen analysis and make sure that there is sperm there, it's moving, it looks normal. And those are pretty much the standard basic tests you're going to get, no matter where you are going for a fertility clinic. Pretty much everybody's going to do those.
Now, Susan, what if I said I'm a fertility patient and my mother had endometriosis and I'm really afraid that I have endometriosis? What would you do in that situation?
So if this was 15 years ago, you would have a straight ticket to a laparoscopy or a surgery for us to look inside your uterus. To look inside your belly, to look at the surface of your uterus, surface of your ovaries, all those types of things. I think nowadays that is much less common. You're going to have an ultrasound, so we should be able to get a good idea if you have endometriomas, so collections of endometriosis within follicles in your ovaries, or within cysts within your ovaries. And then some of it's going to depend on if you have severe pain or things like that. Oftentimes, we kind of make decisions based on all the other factors as to what's going to be your fertility goals, and how many children you want to have, how aggressive you want to be, how aggressive you don't want to be. And so I would say we do a lot less laparoscopy to get that defined, definitive, yes, you have endometriosis, or no, you don't. I know that that's changed even within my career. When I started out, when I was fresh out of fellowship, I took a lot more people to laparoscopy. And what I found happen, and I think this is what we all started feeling, was people. So the value of going to laparoscopy was, do you have endometriosis? If you do, treat it. And also, if it's severe, often we would recommend going straight to IVF, because we know that's going to really be the ideal treatment in the case of severe endometriosis. Well, treating the endometriosis was fine, but very few patients actually use that, is it a big deal or is it not a big deal, as a defining factor, because either they wanted to be aggressive to begin with, or they didn't. And the surgery really didn't phase them in that decision-making process. So, and our treatments in doing things like ovulation induction and IUI and our IVF processes have become so much better, that it really hasn't maintained as much of the value. And we have some good medicines, newer things have come out on the market to help suppress endometriosis chemically without taking the risks of having surgery. So realize, from the surgical perspective, the best abdomen to ever do surgery on is the one that has never been operated on. Okay. And so used to, people might have endometriosis surgeries every couple of years. And what we found is doing that can actually be more risky and have a higher potential of harming you.
You can damage those eggs as you go in and cut into the ovary, right? Yeah, I had that question actually this week too.
Yeah.
So Carrie, in what situation then would you be worried and go in surgically? Like if somebody said, okay, well, I've been told I have cyst in the past and I'm afraid I have another cyst, would you go in surgically for something like that? Or would you go in surgically at all before
So
treatment?
cysts, you have to get more information on that. And you get that information a couple ways. One is by a vaginal ultrasound, because a lot of people label cysts as just normal follicular cysts. And every single month, you are going to have at least one, if you're ovulating, that is, roughly 2 to 3 centimeters. And it's very simple in appearance, meaning when you look at it on ultrasound, it's just a plain black circle. There's no weird coloration in it. It doesn't look like a static ETV. It doesn't have funky shapes. It doesn't have different colors in it, or different shades of gray. And so it's just simple. So follicular cysts, we don't really care about. And in fact, we're glad that they're there, because if they weren't there, it means you're not ovulating. And it's a lot harder to get pregnant when you're not releasing a stupid egg. So that's the first thing that you do. The second thing you do is when you do that ultrasound, you're assessing for size. So let's say you do see something. Something that's 1 centimeter is a lot different than something that is 8 centimeters that's going to potentially cause a problem. And so you want to look at that as well as the appearance. What are the shadows in there? Is this something that looks like a simple cyst where a follicle just got a little overexcited and kept growing instead of releasing its egg? Is this an endometrioma where it's a collection of bloody fluid, affectionately known as chocolate cysts, because God forbid gynecologists not ruin any type of food that we all like by naming some terrible bodily process after it. But you can have chocolate cysts, which are another name for endometriomas. You can take a look for dermoids, which have kind of solid structural components. There's a bunch of different types of cysts. One of the biggest things when people tell us they have cysts is they have polycystic ovarian syndrome, where they hear the name, which is
That sounds
legit,
terrible. Sounds
but
scary.
it's the worst name ever,
It
because it
is.
should be polyfollicular syndrome.
Yes.
And so people hear cysts and then they freak out thinking, oh my God, I have cysts. And in reality, you just have a bunch of follicles that are not really good at listening to instructions, or the instructions are not being given. And so they just sit there eating bonbons because they don't know that they should be growing, or they can't hear those instructions, or the instructions aren't being given. So whenever someone says, I have cysts, there's a lot more deep dive that we need to do into it to figure out, is this a cyst that needs to come out surgically? Is this one that's going to resolve on its own? Is this one we can give medication to get rid of? Or is this one that is a much bigger issue that we need to address?
It's actually kind of interesting because the way it's turned out is nowadays the cysts that you tend to remove, things like serous cystadenomas and things like that, those are actually the ones that probably have the least actual effect on infertility than the others. I mean, it's kind of funny to think about it that way.
Yeah.
And so and every time we operate on cysts, you are going to lose normal eggs. It's just the way it's meant. And we have all seen those people who have come in, they're like, oh, I've had a couple of cysts removed from that ovary. And when we stimulate them, that ovary does not act as well as the other one that hadn't been operated on. And so it can definitely have a significant impact, even though we're very gentle and cautious. It's just, it takes a hit.
So some people may wonder, say I'm somebody and I know I have a high ANA level, autoimmune antibodies, or say I have something like rheumatoid arthritis. Is that a cause for infertility? Is that part of our unexplained infertility? Like would that person be unexplained or explained if she had something like rheumatoid arthritis or some other medical condition like a clotting disorder or something like that?
A lot of those people would be grouped in unexplained, because though we know that there is a relationship, there is not something definable, like saying diminished ovarian reserve. You have tubal factor, you have male factor, you have known endometriosis, you have, those types of things. Those are those things that fall into that gray zone, that we know that there is a relationship. We know that it's reasonable that these things can go together, but we can't pen a name on it.
Yeah, I think of unexplained as kind of what we've just talked about is uterus, tubes, ovary, sperm. If those things are all good, we don't find any abnormalities, that's kind of the definition of unexplained. But I agree that some of those other things, clotting disorders can have a bearing on outcome. I mean, a bearing on outcome and fertility and things like that too. Anything to add, Carrie? What are your thoughts on that?
I think that one of the more helpful sets of explanations that I've started to do with some of my patients, and there's a little bit of profiling that goes on here. For example, if I see you're an engineer, we're going to have this discussion straight up, because they want answers.
They want to know if there's a problem, there's got to be a way to fix it. So you got to figure out how to fix it if they're an engineer.
Exactly. And so the prophylactic discussion that I've started to have with people, especially when I've got a decent suspicion that I'm going to get totally normal testing, like, they're both in their early 30s and they're super healthy and all those things.
Yeah.
I always tell them up front, look, I'm going to test for all these things. And if there's something weird, I'm going to go after it and we're going to look into it deeper. But you need to know that the unexplained infertility is when all of that testing is normal and you still can't get pregnant. And that accounts for about 15% of infertility. And even though it sounds like a nothing throwaway diagnosis, it's not, because there are treatment plans that are entirely based off of unexplained infertility. It is its own standalone identity. There are
It does not mean
researchers.
there's not a problem. That's one
Does.
of the big things, because a lot of people are like, oh, I have unexplained infertility. That means you couldn't find anything, so there's really nothing wrong. That is not true.
Mm-hmm.
We may just not have a test for it yet.
Exactly. And so that's where having that discussion straight up helps kind of diffuse some of the anger and anxiety that goes along with, what do you mean I just went through all those tests and you still don't know what's going on? It's that I've done all the stuff I can. There's still a problem. It's just we don't have the capacity to test for it right now. And so we approach it with the treatment plans that address unexplained infertility, which the bulk of those are trying to figure out how do we optimize everything we can optimize so that if there is an undiagnosed or undiagnosable problem in there, we're addressing it, even though we don't necessarily know that we're addressing it because we don't have the test to prove that's what we got to address.
And that's a very important point, is just because we can't say exactly what the problem is doesn't mean we don't have a solution.
Yeah.
Okay. And so that's one of those things that takes a little bit of a leap of faith, but we actually have studies for some of these things we're about to talk about that prove, in the scenario of unexplained infertility, all the testing is normal. These are the things that work.
Mm-hmm.
Yeah, and it's not a bad thing to have normal tests. I mean, on the flip side,
A lot of times when we have abnormal tests, there's not a lot we can do.
right. I remember a time when I was just shortly out of fellowship, and I had this patient who had just terrible endometriosis after we had done surgery because she had some endometriomas. And, she was like, I'm so glad you found that. And I'm like, well, yeah, I'm glad we know why. But now what this means is we're probably going to have to do a lot more aggressive treatment. And so it's not necessarily bad news when we don't find out the answer. And my version kind of your talk, Carrie, is, people sometimes spend their whole careers trying to figure out what happens in the first 24 hours of fertilization and implantation.
Mm-hmm.
And there's probably millions of things that have to happen for an egg and a sperm to get together and to implant. Unfortunately, we just don't have the test for those. And so I actually see it as a positive thing because there's not anything really bad. And kind of like what you said too, Susan, it's kind of like layers of the onion. The more things we can kind of fix and help and boost, and better chances we have of successful conception. So, Susan, what are some things that you would tell me about your treatment plan for patients who have unexplained infertility?
So really, my treatment plan for people who have unexplained infertility, the two main things that I'm going to offer are some form of super ovulation. So the female partner taking medications to boost her egg production that month, and using that in combination with IUI or intrauterine insemination. So that's one option. Or looking at IVF or in vitro fertilization. And those decisions as to which one it is going to be very tailor-made based on that individual or couple's desire for family size, timing, how aggressive they want to be, how much money they want to spend. I think they're both very good options on places to start, but which one is going to be the right one for you is really going to be dependent on your particular situation.
So, Carrie, if somebody wanted to start out with kind of the least expensive, least involved treatment, what would specifically would you treat them with?
So usually I would go straight to a medicated IUI cycle because that addresses a little bit of everything that it can address, short of IVF. And so what we're doing is we're saying, okay, we're going to do a baseline ultrasound and we're going to make sure that everything is quiet to start off because that's eliminating that there's some obvious ovarian problem where the system is starting to be activated early. Then we're going to give either Clomid or Letrozole typically, where we're trying to get the eggs to grow. So we're giving a little bit of a boost. It's just a slight nudge to the brain to produce the instruction hormones. And then from there, we do another monitoring ultrasound to make sure it worked. Because if it didn't work, then we know, okay, we need to do something differently. Once we know it did work, and also that it didn't work too well, because the goal is to give you a baby, not a basketball team. We know that we've got those 1, 2, 3, however many follicles that have grown, and then we give you a trigger shot to release them because it's not sufficient for it to be there. Those eggs have to release as well in order to be useful. And then 2 days later, we do the sperm preparation and put the sperm in because we want to get them as close as possible. We don't want them to get hung up on cervical mucus or have a motility issue that means they can't make it through. And then from there, we usually give a little bit of extra progesterone to supplement some of the hormonal environment after ovulation occurs, so that if that's what's needed, we can do that. And then we wait and we see what the pregnancy test is. So typically, if you're going for the least involved, you start with IUI cycles, again, with the goal to optimize what you can in the least invasive, least expensive way possible. Now, that still has the downside of IUI cycles have success rates that are about 12 to 15% in the best case scenario where everything looks good for it. So as with any treatment discussion, you got to make sure your patients know these are the pros, but these are the cons. And so some people will be well suited for that and some people will not.
So, one quick follow up: what's rough cost for that
So
for our listeners
hi-
that maybe have not started all this process yet?
So highly variable, usually in the area of a couple thousand. Insurance is way more likely to cover IUIs because it's cheaper, because they're fine paying with something that's less expensive, even though it's way more ineffective. And ultimately, they're going to end up paying more because they're going to have to do more. But that is a separate soapbox that I will hop on later. So it's a considerably less expensive treatment.
So, Susan, I know we probably a third of our episodes have something to do with IVF, and we've talked ad nauseum. But for listeners who've never listened to those episodes, can you just give us sort of just an overview of IVF and just why it might be something that they might want to do sooner rather than later?
Right. So the general premise of IVF is we're going to give you medication to stimulate your ovaries to create multiple follicles. Those are the houses of the eggs, to have multiple of them grow at the same time. When they get to the right stage, we will then do an egg retrieval. We'll actually get those eggs outside the body, put eggs and sperm together outside the body, usually let them grow out to the day 5, 6, or 7 stage. Usually, often do testing on the embryos, something called PGT or pre-implantation genetic testing. Those embryos generally will get cryopreserved. We'll send that sample off and find out if your embryos are chromosomally normal or not. The reason why that part is valuable is that even when you're in your 20s or young 30s, at least half of your embryos that you're creating are chromosomally abnormal. As you age, that percentage increases. And when we're able to put back a chromosomally normal embryo, that's when you get those higher pregnancy rates in the 60 to 70% range. So when we're doing IVF, one, not only is it therapeutic in that we have much higher chances in getting you pregnant, but it's also diagnostic. There are things that we don't know about how your eggs look or your eggs and sperm interact until we actually have them in a dish. So when we do an egg retrieval, our embryologists, those are the people in the lab who are specially trained to deal with egg and sperm, like they can tell us all kinds of things about your eggs, whether they have fragmentation in them or the zonas, the little shell around them are cracked or don't look healthy or too thick. There's all kinds of things that we learn. And as we look at embryos during that week, as they're growing, how they're progressing, are they progressing at the right rate? These are all parts of the diagnostic process. And so we tend to get much higher chances of success even when we have unexplained infertility. And it's a valuable part of the learning and diagnosis phase as well.
So what's the cost to success ratio for that?
Right. So IVF, if you do not have insurance coverage, again, can be very variable depending on where you live. If some people, more and more people are getting insurance coverage, but not everybody does. If you're cash pay, I would say somewhere between $20,000 to $30,000 is going to be average in the United States.
And
And some of
success
that's
would
going to
be,
depend on how much. A lot of that variability is going to depend on how much medicine you need.
and success,
Success,
roughly.
if we can get a chromosomally normal embryo, is probably going to be 60 to 70%. But that likelihood of getting that chromosomally normal embryo, that's really something you need to talk to your reproductive endocrinologist about,
Mhm.
because there's so many factors: your age, your ovarian reserve testing, what this, if there's something additional that we need to know about the sperm. Granted, this is unexplained infertility. So most people with unexplained infertility are going to have relatively high success rates, but age is going to be probably the biggest variable factor
Yeah.
in that. So if
Female age.
female age, if you're sitting here, listening to us and you're 32, that's a different prognosis than quote unexplained infertility at 42, though
Right.
I would not call unexplained infertility at 42 truly unexplained infertility in most cases.
Yep.
So, Carrie, I forgot to ask you cost to success rate for doing oral ovulation induction and intrauterine insemination, roughly. What's the cost? And you tell me the cost, I think. A few couple of
Yeah.
$1,000. And then what's the success rate?
Oh, so success rate is 12 to 15% in the best case scenarios, but can rapidly drop lower than that. Again, age really has a large portion in this, and whether or not you've got a higher suspicion, even if you don't know that there's a tubal factor due to endometriosis or something along those lines. That's kind of what we're looking at there. When you're just doing straight ovulation induction minus the insemination component of it, at that point, I mean, just a Clomid cycle without any of the rest of it is maybe 5 to 9% at best. So usually it hovers a little bit closer to that 5% for most places. When you look at a couple's trying to conceive after they've been unsuccessful for over a year, at that point, you're looking at a 1 to 3% success rate just on their own. So going from 1 to 3% up to like 5-ish% is not terribly appealing to most people.
And how long would you do that? Because some people kind of feel like, well, maybe I didn't release the egg. Maybe I should try this for 6, 8, 10 months. What do we usually recommend? Not 6,
So
8, 10 months, right?
not 60. Yeah, not that long, that's for sure. So some of it depends on what the situation is. We're going to have a longer leeway time period with someone who's 28 and someone who's 38 and someone who's 48. And so that's a part of it. Knowing what your ultimate family goals is going to play a part as well. But I would say typically about 3-ish months is where most of us land. You can make an argument out for 6 months, depending on what the circumstances are. The biggest thing that I worry about in those cases are folks who say, I'm just going to go off and try this very low yield success rate, and then I'll let you know when I'm ready, which is totally fine. But the danger in that is the frustration factor of, well, we know we had sperm there. We know that the eggs were releasing. Why the hell didn't this work? Therefore, this will never work. Therefore, I quit. Therefore, they come back to me in like 5 to 7
5 years. Yeah.
and now it's no longer unexplained because we know that the age is having a major impact and the egg quality is craptacular. And so that's the biggest concern that I have. Like, it doesn't bother me when people want to do the really low intervention styles first. It's just, okay, we're going to do this for 3 months. And if it doesn't work, this is what we're going to do next. And we're going to do that for 3 months. And if that doesn't work, this is what we're going to do next. And just kind of have a plan, because life will happen, frustrations will happen. And let's just kind of have a guideline of, this is about what we're going to do so that we stay on track and we don't lose sight of what we're going for.
So an important thing for our listeners to also understand, there are actually published studies out there looking at why people drop out of fertility care. And though most people would expect cost to be the number one factor, frustration is
Mhm.
actually the number one
Yeah,
factor.
that's
And
right.
so it's important to know yourself and know what your limits are. So when we're saying things, as a lot of these things that we're looking at, there are not a lot of hard and fast rules. There's a few, okay?
Mhm.
But most of what we're talking about are guidelines. And so, if you're like, there are some people who are definitely more chill than others. Okay. I am not a chill person. Like, okay. I'm like, let's get this done. Let's move on to whatever. Okay. But if you're a more chill person, you're like, you know what? I know we've done 3 and we really want to do this a little bit more. We're not too super stressed about this. There are other people who this is all consuming. It is absolutely all consuming.
Mhm.
And it is important for you to share that because with your reproductive endocrinologist, because we're pretty good at reading people, but
Mhm.
realize we're reading 2 of you in most cases. Okay. And so sharing with us where you are in your journey is
Mhm.
very important because there are some people on their first visit, they are very close to the end of their journey because they just don't have enough emotional
Bandwidth.
space, bandwidth left. And there's other people who are not in that situation. So, like I said, we're pretty good at reading people, but also know that we're here to help you and we want to get you where you need to be in the time you need to be there.
And I
Mhm.
think there's a subset of people too who get really caught up in the diagnostic part of it. They really, really, really want a diagnosis. I have a patient like this right now that just is hoping that she gets some diagnosis because I don't know, for some reason that's going to make her feel better or feel like there's something she can focus on. With this is a little more vague and nebulous. And so for some people that really just derails them, like you were saying, Carrie, they can't get past that, And I think the key is it's kind of one of those things in life. I think the more resilient and the more determined you can be, the better. So I think the people that I see that tend to do the best are the people that are like, okay, we've done all this. We don't have a diagnosis. That's okay. Our end result is we want a baby. What do we have to do next? What do we need? What do we do after that? That
Mhm.
doesn't work. What do we do after this? Those are the people that really, not all, but a lot of them are able to get there quicker and they have the outcome they want quicker just because they're willing to just accept it and move on.
Spending more time and looking for really esoteric testing that probably doesn't have a lot of validity because honestly, if your doctor's not offering it, 9 times out of 10, there's there's probably a reason for it. And if you're concerned, ask. Okay. But don't be like, we just need to do more testing until we find a reason because we may not find it
Mhm.
maybe for a couple of years or ever in your reproductive life. I mean, I think one of the best examples is now we have the test Spern QT available. That's an additional test we can look at sperm. Okay, it's fantastic. It gives us answers we did not have 5 years ago.
Mhm.
Okay,
Or
those
2 years
people
ago.
or 2 years. So those are people who now have a male factor diagnosis that previously had unexplained infertility,
Great point. Yeah.
but we had no idea when this technology was
Mhm.
going to become available. Now it's
Yep.
available. Great. We have more answers, but we can't tell you when that next bump in technology is going to be available. And
Mhm.
it's not in most cases worth finding the answer. It's better to move on to getting to your goal.
Yeah, and I would just second the esoteric. That was a great point because a lot of
Mhm.
people will go looking. If they can't get it from the test that we talked about, they'll go online and look for a lot of things. You're going to spend a lot of time and probably a lot of money to find something that's not going to be helpful. It's not really in the long run going to be helpful for your journey to get you quicker to where you need to be.
Mhm.
All right. Any other thoughts?
I think we've covered a lot about unexplained infertility.
Awesome. Well, to our audience, thanks for listening. Tune in next week for more. Be sure to subscribe and leave a review in iTunes. We'd love to hear from you. You can follow us on Instagram or Facebook. We have a new IVF book coming up hopefully soon. And so give us your ideas about that as well. And we'd love to hear from you.
You can also visit fertilitydocsuncensored.com to submit specific questions about infertility. All questions will be answered on the podcast anonymously from the Ask the Doc segment, so don't hold back. We love episode ideas. Let us know what you're thinking, what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.
Bye.